we need extensive rerouting? Rerouting means making a different route, right? So as you know, the most important extensor muscle of the thumb is extensor pollicis longus. Extensor pollicis longus. Extensor pollicis longus make a long way like this. That means we have a lesser tuber group. It's a kind of landmark. The pollicis longus passes just on the side this. But the patient with a long-standing flexion deformity of the thumb, they also do have a weakened extensor tendon. So we want to make more. We want to get extensor pollicis longus tendon more strength. So how to do that? We want to make a more straight route. So. And after cutting the extensor pollicis longus tendon distally and put it proximally and making another strip. This is a schematic. This is an intraocular picture. This is original path of the extensor pollicis longus, and we want to make a more straight route for this tendon. This way. This is an intraocular picture. This is my. And then finally, I should show the thumb arthrodesis. Frankly, I have only done with some arthrodesis, whether it is IB joint fusion or IB joint fusion, just one case, which was for 37 years old patient. So this is my case. But this is my friends, David's pictures. Many patients, especially elderly patients, have very relaxed, very relaxed flexor side of the metacarpal thumb. So in the case, you cannot do any kind of reconstructive surgery. As you know, reconstructive surgery means making a joint almost normal. But the tendon muscle, when the tendon muscle is already gone, we cannot do reconstruct the joint. So in that case, we want to have the salvage procedure rather than reconstruct. So this is an intraoperative findings of metacarpal joint arthrodesis. There's another one. Fingers. So finger tendon is very simple. I do not know how you guys are lengthening the tendon, but my way is to after general anesthesia with the anesthetician, I can check each 5 fingers by palpating the IP joint, PIP joint and PIP joint. When the PIP joint is out, you can simply lengthen the flexor distal. When the DIP joint is very tight as well, we can lengthen the flexor distal profund, etc. So it's very simple. But I strongly recommend that you need to be very careful because sometimes in the elderly patient, the range of motion after lengthening in the opening does not correlate with the function after the operation. So I used to be very careful. Some people, especially some people, doing shortening surgery or the forearm itself. So I think there's another options, but I have no experience with it. So this is I pick up this actually for the most severe cases. So I usually do not like this, but this is very good for illustration. So you can show all the facets and this is the last one. So and all elderly patient and people can have swan neck deformity like this, and then Swelling deformity is caused by long-standing spastic extensions. So we can mobilize the extensor to the flexor side. There is a kind of tendon transfer, but in this specific case, we call it tendinosis. Tendinosis is more like a salvage procedure rather than different surgery. This pin is about just an intertemporary mobilization method. This is pre-op. This is pre-op. After doing the tendinosis, we can have steady improvements, and after aggression rehabilitation and bracing treatments, we can make patients and reasons. So this is a practice. Thank you very much for your attention. Tomorrow I might do this very much better. Thank you. Any questions? We have another discussion on the session.
I don't do it awake. Children, I don't do them when they are awake. So, in India, at least in the Indian setup, it has to be a surgeon typically who has to inject botulinum toxin in children. There are instances where botulinum toxin is injected in children without anesthesia.
Do you use an intraoperative ultrasonography?
Yeah, intraoperative. So, for accurate targeting.
Do you have any other kind of surgery you are doing for the hand and wrist problem?
Yeah, absolutely. So because what we tend to do is use botulinum toxin as a preoperative test.
Mm-hmm.
So, because as you said, ocular surgery is very unpredictable.
Mm-hmm.
What you see in the post-op and anesthesia doesn't correlate with function.
Mm-hmm.
So sometimes we give the botulinum toxin as a test to see if there is improvement. And then if there is improvement in function, then we follow it up with similar surgery. So
I would say the most predictable operation regarding surgery is to 10 to 11, 12 years of age, immigrant patient, and a flexed elbow with technology.
but is it that too late? Haven't they gone into a sort of
10 to 12.
learned misuse or non-use of the hand?
10 to 12 years of age.
Yeah.
But I mean the patient has been treated properly in the rehabilitation program.
In India, we probably don't have that sort of structured rehabilitation setup. And we probably have to intervene a lot earlier. The ones who have been left until 10 or 12 years without any intervention, they probably have severe fractures and they probably have poor.
I think you have a very important role, the intervention already.
Yeah, and expectations are high as well. So it's very difficult to manage the upper and no one follows a proper rehabilitation program. So they do it for 2 or 3 months and then they won't do anything for 3 years. And then again they do it for a couple of months and it's like that. So because we don't have a public health system, a good public health system.
So I definitely sense we need a dedicated occupation service because in Korea the salary is not good. So also they're very difficult to deal with the small kids and their parents. So many younger people don't want to go about this. That's another factor. So I would say the safety kids treatments with the research or pet research is very participatory. So the surgeon's role is very limited. The surgeon need to find out what the best treatment time or the best treatment time and what the best is. And that's a very
orthotics is there. When you see orthotics, basically orthotics are designed for 2 primary purposes. The first purpose is basically affecting the body. When we see we want to get alignment, the body structures, and in few cases it can assist the function also. And in most of the cases it can be combinations of both body structure alignment and functional assistance. When we say about orthotics, it can be for upper limbs, lower limbs, and truncal spinals. So, if we describe about the lower limb orthotics, the aims are again more or less same, but the first aim is to correct or prevent deformity, to provide a base of support, to facilitate training in skills that helps in enhancement of postural skill, to improve the cardio for so long. Spinal orthotics, the aims is basically to reduce the spinal curvature, to improve the seating ability. This is very much important with when you say FCS level 5, level 4. It may prevent forward leaning. This is very important for hand functions. And in fact, improving pulmonary functioning also. This is also one of the important factors for spinal orthotics. When we go for orthotics designing, prescription is the most important, but before prescribing any kinds of aids, we should assess the child. Now, basically, there are so many theories available, but the last advanced theories is basically depend on the mobility skills. So, assessments are very thorough, and every child should be assessed in isolations. All the joints should be seen, the range of motion, the strength, the sensation, all these factors should be considered. International consultants describe the assessment basically into three parts. When you see a child, the child can be in the pre-standing child, the child can be standing child, the child can be walking child. So if you are going to prescribe a kind of orthosis, you should classify the child first. If the child is pre-standing child, the basically need will be very much different from the walking child. Now, when you are getting basically the assessment done, you should have a very good clear-cut diagnosis, because the role of orthotics, upper limb orthotics are very much different from the bilateral spastic cerebral palsy, there is called diabetic cerebral palsy. Again, you should see the GMFCS level, how the child is basically doing, the functional ability, range of motions, both passive and active, selective motor control, it is very much important, strength, spasticity, and again, the joint alignment. This is one of the important, where the alignment can be assessed by radiological also. In addition to the assessment, we should see the gross motor level of the child. So sitting, standing balance, if possible gait analysis, available gait analysis should be done, because gait analysis helps to prescribe good orthotics. We should see the environment, because all orthotics does not work in every environment. We should see the behavioral characters of the child, and any element associated condition if the child has got, as for example, if the child is having epilepsy, if the child has got GER, and the child is using stomach feeding tubes, you should consider different way. The same kinds of orthotics are not going to have the child. When you prescribe orthotics, there are a number of orthoses are available, but the most common orthosis we are using basically medial arch, which is SMO, AFO, the generalized orthotics is AFO. In 90% cases of the children with cerebral spastic cerebral palsy, they are using AFO, GRFO, FRO, which has been basically described early in the morning with crouch gait, AAFO, STFO, gaiters of these beams and others. These are the most important, you can say, generally available orthotic aids with cerebral palsy. In the case of basically KFO and SKFO, when we are prescribing these two, we have to assess the child very clearly, because these two orthotics are using multiple joints. And in the case of multiple joint orthosis, the negative impact may be more than the positive impact. So SKFO and KFO are used selectively in the children with cerebral palsy. Generally, SKFO is not being used because it is not necessary with the children with cerebral palsy most of the time. When we say spinal orthosis, very limited spinal orthosis are available. The most common is called TSO and thoracic lumbar orthosis. This is basically used for those cases where you are getting scoliosis. Upper limb, in the case of upper limb, there are so many orthoses available. These kinds of orthoses are very common, but different design of orthoses are available nowadays. When we go for AFO. Describe about AFO. AFO is basically the most common in according to the latest survey. The latest survey says more than 90% children with cerebral palsy, spastic variety uses AFO. AFO is ankle foot orthosis. AFO can be many types. This can be multiple types. Solid AFO, that is also called CAFO. Posterior spring orthosis, PLSO, these are very essentially used. Hinge AFO, these are also being used in so many cases. This is the picture of basically called SMO. In other words, this is called post-supranuclear ankle foot orthosis. When a child has got tightness or say only problem with valgus, the plantar flexors, especially the gastrocnemius soleus, is not so tight. The SMO can help the child to get foot alignment. It basically help to get the foot alignment. You can basically divert the foot placement, the foot weight from the medial side to the lateral side. This basically provide increased subtalar joint control. It is not used in every cases, but in few cases you can use SMO also. AFO. This is particularly very much beneficial with most of the cases of cerebral palsy. This is called solid because it is rigid. It is one piece. It has no joints. It is the basically maximum orthotic control. You can say restricted plantar flexor versus flexors. When you see a child with crouch, the solid ankle orthosis, foot orthosis is better than any other orthosis. Although you can use FRO, but the FRO efficiency is still controversial. A number of studies do not have the role of FRO in the case of crouch. Dynamic ankle foot orthosis. Nowadays, dynamic foot orthosis is basically has been modified into another name that is called limited joint AFO. In dynamic, there is a joint. The joint in early days, the joint was complete. You can completely dorsiflex the AFO to 0 degree. But studies say there is no need to go for more than 20 degree dorsiflexor. So now, hinge AFO, the dynamic AFO has been modified to limited joint AFO, where the child gets only 50 to 20 degree dorsiflexors while mobility. And there is no plantar flexors, now plantar flexors basically possible with hinge or limited joint AFO. This AFO has been used basically, you can say, after solid AFO. Again, percentage wise, a large number of percentage of children use these kinds of AFO. Posteriorly, spring orthosis, these are also being used, but this has got so many, actually, you can say, negative impact rather than positive impact. These kinds of orthosis are not being used for obese children, heavy children. Again, you can use for those children who have got calcaneus foot. So it has got definitely a role, but a limited role with mild to moderate plantar flexor tightness cases. This is again modifications of solid AFO only. In the case of solid, that is called SAFO, you have seen the circumference is limited. It is not fully covered. When the circumference, that means the calf, is fully covered from anterior and posterior, then it is called circumferential AFO. These are being also being used again in limited number of cases. This is called hybrid plastic ankle foot orthosis. This has been modified, the straps have been modified according to the need, and the heel has slightly been raised, that is why it is called hybrid. Nowadays it is also being used in so many cases where the child needs a few degree of plantar flexors while walking. This is hinge, again customized according to the need of the child. This is in other words I can call modified limited joint AFO. Yeah, this is FR. This is also called GRFO. This actually was discussed early in the morning by Dr. Abhay to use when the child has got crouch kick. But again, when the child has got very severe knee flexors, contracture, the child cannot use these kinds of orthosis because it is very discomfort for the child. These are so many, these are just varieties of the AFO. This is called KFO. KFO is basically ankle knee foot orthosis. When the knee is also covered with the ankle, then it is called KFO, KFO or KFO. It is being used basically as a light split rather than in the mobility. The research study says when you are If you are allowing the child to walk forward with a KFO, you are basically harming the child rather than helping the child. The child will use hip hiking because there is no possibility of the flexion and extensor. So it can be used only for side walking in the mobility training, and it can be used for the night sprint because it is considered as one of the very good stretching aids. And according to the studies, stretching of the muscles manually is not considered better than